complex. And then, of course, the slow rates, where you have asystoles and bradycardias, is very easy to detect. Fast ventricular rates is also easy to detect. It's a matter of timing, where you have fast and very fast tachycardias. For atrial fibrillation, that's a little bit different because, as I said, we don't look to the small signals in here, the atrial signals. So how do we detect atrial fibrillation? We do that on the basis of, there's something wrong on this slide. We do that on the basis of successive RR interval changes. So we measure the change between these two successive intervals and the change in these two successive intervals. And we plot one on the x-axis and one on the y-axis. And then you get what we call Lorentz plots. And this is a typical Lorentz plot of a patient with atrial fibrillation. Your ventricular rate gets very irregular. This is a plot of atrial flutter. Normally here you have a very stable ventricular rate. And this is normal this is also atrial flutter, but with different conduction ratios. So you get not one cloud, but you get 2, 3, or 4 very specific clouds. So for every atrial arrhythmia, you can identify a very typical Lorentz footprint. So any monitor is able to look at all these possible footprints, and by means of the footprint, it will determine whether the rate is sinus rhythm, or is atrial fibrillation, or is atrial flutter. So why did we choose to monitor atrial fibrillation? First of all, because there is a lot of literature that there is a very poor correlation between symptoms and atrial fibrillation. Many AF episodes are asymptomatic. About 9 out of 10 are asymptomatic. But also patients may have symptoms that have nothing to do with atrial fibrillation. So they feel that they have an arrhythmia problem, and it's not. It is maybe congestion or something else. Well, if you do intermittent monitoring, you give the patient a 24-hour or even a 7-day Holter, that almost always leads to under-detection of atrial fibrillation. Atrial fibrillation comes in storms. You can have 3 months with no atrial fibrillation and 1 week with a lot of atrial fibrillation. So snapshots have very little value. And up to now, continuous monitoring was only possible with therapeutic devices like ICDs or pacemakers. This is just an example to show how poor patients can tell their own heart rhythm. This is from patients that had a cardioversion, so they had atrial fibrillation, they were shocked, so the atrial fibrillation stopped. After 1 week they were asked, what do you think your heart rate is? And of the 134 patients that were again in atrial fibrillation, only 38 could tell that they were actually in atrial fibrillation. The vast majority had no clue, and 30 patients even thought definitely they were in sinus rhythm. Also, the issue of snapshot monitoring. This is patients that had a pacemaker implanted. Well, a pacemaker also can monitor continuously 24/7. And this is from 250 patients with a dual chamber pacemaker, where they looked at some ECGs that they took during the follow-up of the patient. And they found only something like 10%, 15% of the patients to be in atrial fibrillation, if you base it just on the ECG during follow-up. If you base it on what the pacemaker tells you with the data that it is stored in the memory, you see that only 40% of the patient is free of atrial fibrillation. So the more you look, the more you see. That's definitely true for atrial fibrillation. So the benefits of continuous AF monitoring is you will find more, you really have a true impression of the AF status of the patient. That includes asymptomatic atrial fibrillation. And of course you can use it also to see how effective your therapy is. Because how are doctors treating AF? I think the problems in AF are twofold. The biggest problem is the thromboembolic risk. So the risk of a stroke or a TIA. There is relatively good therapy for it, but you have to know that you have AF. That's the problem. The other issue with atrial fibrillation is to reduce symptoms. Many patients have palpitations, And so your doctors use drugs for rate or rhythm control, drugs or even invasive procedures like ablation. And it can also worsen other comorbidities like heart failure or ischemia. What we are focusing on at this time is patients with cryptogenic stroke. That means these patients had a stroke, and the physician, although they looked very carefully, they could not find out the reason why the patient had a stroke. And that is also, again, that is about 25 to 30% of all the patients that have a stroke. They cannot find the reason why these patients had a stroke. And so if you cannot find the reason, what do? The guidelines say you have to give the patients aspirin, and they only reduce the risk of a second stroke by a limited percentage. If the patient also has atrial fibrillation, then you can give the patient oral anticoagulation, and that reduces his stroke risk by something like 80%. So if the reason was atrial fibrillation, you have the bingo, because then you can give the patient a very effective therapy. And so that is based on what they call the CHETS-2 score, where you need to have, I think it's here, you need to have 2 points or more to start warfarin, that is the oral anticoagulation. And the 2 points you get already from a prior stroke, because that is the only risk factor that gives you 2 points. So if you have a patient with cryptogenic stroke, you are able to detect atrial fibrillation, you have the 2 points, you can start warfarin in that patient and reduce the risk of a second stroke by 80%. And a stroke, I heard one patient, and I think it's a very valid quote, he said, it's worse than dying than a stroke. So it's something that you definitely want to prevent happening a second time. This is data from one center. I think the center was in Spain, if I remember well, where they looked very extensively to patients with cryptogenic stroke in many different ways. Just one ECG, multiple ECGs, 24-hour Holter, 7-day Holter. And you can see the longer you look, the more you will find. 17% of the patients with cryptogenic stroke had atrial fibrillation in this study. So if you do continuous monitoring, I'm pretty confident that we will have 25, maybe 35% of the patients with atrial fibrillation. And we will help these patients enormously. Something about congestive heart failure. This is from a study that looked at how patients were managed with heart failure. The usual care, you see the doctor every 3 months, or the nurse support, the heart failure clinic, which is very popular at these days. And what this study has shown is that the survival of patients that were under